Rahim, MD, is the Medical Director of Stroke and Neurocritical Care at Mission Hospital in Mission Viejo. He is triple board certified neurointensivist and vascular neurologist with a strong academic foundation with over 2 dozen publications.
आप बता सकते हैं इसको कैसे करना? ये मैं I don't want my picture to be seen.
He completed 2 fellowships in critical care and stroke at Stanford University and his residency from Virginia Commonwealth University. After working at Stanford, he took on a role as the medical director at Mission Hospital. So welcome, Dr. Rahim. It's really a pleasure to have you. Would you like to say a few words before I share your presentation? You're muted. We can't hear you.
Assalamu alaikum, everybody. Thank you for inviting me to give this talk. Stroke I'm very passionate about stroke. I did a lot of research, and my fellowship is in stroke and neuro ICU. So very passionate about, treating stroke and preventing stroke as well. So if you don't get the stroke, you're ahead of the game. So that's, I do dedicate a lot of time in our community in Mission Viejo, and I get this opportunity to talk to you as well to help with that. So I'm going to get started with my presentation about stroke care and prevention, what does stroke mean, and what kind of facilities we have in our community. So
now, yes. Do you see the presentation, Doctor?
I do.
Okay, wonderful. Let me know.
I'll just tell you next slide. Okay. So we at Mission Hospital, we are a 523 licensed bed mission hospital in Mission Viejo. So we're one of the furthest southern stroke center in Orange County. There's a lot of stroke centers in Orange County, little out of proportion to other places in the United States, a little bit more. So that's good because every center will have resources. You see these 3-star, if you see these right-sided, you'll see 3 stars. These are the comprehensive stroke centers. And the comprehensive stroke center is the topmost accredited hospital for stroke care. And we have St. Jude, that's in northern Orange County. Then we have UCI in middle, and then we are the only one that's serving the southern Orange County. So there's only 3 stroke centers in Orange County that are capable for handling complex stroke cases. So we do treat over 80,000 people annually in our ED, and we are Joint Commission certified, and we've received all these awards as well. Next slide, please. So facts-wise, one American dies of stroke every 4 minutes. It's very, very prevalent, and it's the 5th leading cause of death in Americans. Now, it used to be 1 or 2. However, with recent research in stroke, it's gone down in the cause of death, but it does cause a lot of disability. So there's always going to be somebody that knows a family member or their loved ones where they will have disability from a stroke. So it does hit home very personally. Yeah, especially, even in my family. Next slide. So stroke is a medical emergency, and you have to treat it like a medical emergency, like a heart attack. This is essentially a brain attack. Every minute, there's lack of blood flow to the brain is dying. Next. So the stroke is a general umbrella term. It's divided into 2 different types. Ischemic, which means there's a clot in the brain that's blocking blood flow to the brain, and there's also a hemorrhage where hemorrhage, also called fallage, a lot of people call that, but that's a brain hemorrhage that occurs in the brain, usually due to high blood pressure. So stroke is an umbrella term, and under it, majority of it is the clot type, and then some of it is hemorrhage. So 85% is the clot, 15% is a hemorrhage. Next slide, please. So on the left side, you'll see that there's a there's an artery in that little circle that a clot is moving up and then it stops moving where it can't go any further. Just like general basic plumbing, a clot will go down until it can't go any further. And at that point, the brain that's supplied blood flow to that area is going to lose blood flow, and that brain is going to die. Okay. So, and then on the right side, you see a brain, an artery that ruptures. You see all that blood coming out of the artery. That happens when somebody has high blood pressure. So that's one of the types of bleeding type of strokes. So this is an animation of what two different types of strokes there are. Next slide. So symptoms of a stroke is very sudden. So if I stop blood flow to the brain, the symptoms will come on immediately. The brain is very deprived of oxygen and it stops working at that moment. And so if you have sudden onset of weakness, numbness, tingling, understanding people, or inability to talk or slurred speech, these are signs of stroke. Vision is one, double vision, blurred vision, dizziness, loss of balance, and unstable walking, that's part of it as well. You can have a combination of these, or you can have just one. And then a severe headache is sometimes also in the bleeding type of strokes. You can have a severe headache as well. So any kind. So if I have a stroke on my right side of the brain, I will have symptoms on my left side of the body. That's how the brain works. The right side of the brain controls my left body. So if I have numbness, if I can't move my left arm, that tells me that I'm having a stroke on my right side. Or trouble speaking, trouble talking, or trouble understanding. Sometimes the vision is the back part of the brain here. So if I have a clot there, I'll probably have vision with left side of my vision that will be gone. So any kind of neurological symptoms, vision, weakness, numbness, or dizziness, these are classic signs of stroke. Now, dizziness has some overlap with ear problems as well, but that can be difficult to decipher sometimes. But the other ones are very prominent, very, very clear cut. Next slide. So up to 50% of all strokes are preventable. So what can we do about it? So can we prevent stroke from occurring? Absolutely. And that's half my job, is to prevent strokes or prevent a second stroke in the patients who may be admitted for a stroke. So some of the symptoms, some of the things that we can talk about are risk factors. And some risk factors we can control. Some risk factors we can't control. Like age is a risk factor, unfortunately. But you can't, go back in time. So those are uncontrollable risk factors. However, things like smoking, cholesterol, high blood pressure, those are controlled risk factors. So I define two different types of risk factors: controllable and non-controllable. Also called modifiable. Can I modify my cholesterol? Yes. So that's modifiable. Can I modify my age? No. So that's non-modifiable. So we'll talk about those. Next slide. So we'll talk about uncontrollable risk factors, non-modifiable. Age. Age, as you age, blood vessels in your brain, your heart, your rest of the body, age as well. So they've been, dealing with all this stress, and I'm not talking about like mental stress. I'm talking about like physical stress of blood vessels flowing and cholesterol and things like that. And over time they get hardened, and then sometimes they stop working. And that's why age is a very big risk factor for stroke. And stroke incidence doubles for each decade after 55 years of age. It's something, this uncontrollable. Unfortunately, we can't do anything about the age, but we can modify all your other risk factors to prevent strokes. Next slide, please. Gender is one of them. So nearly 60% of stroke deaths are women, and
Ooh.
stroke kills twice as many women as breast cancer. And so what happens is that incidence is higher because women live longer than men, and that's a fact. And higher rates in younger ages can be linked to oral contraceptives, hormonal effects, and postpartum state. So what happens is that in the beginning stage of the life, men are a little higher risk of stroke. So men will get strokes in the 50s, 60s. And then women, as the post-menopause, catch up. And then they actually, because they live longer, they have higher risk. So men are higher in the beginning, then women catch up and actually go past because of their overall health is better, but it is a very prevalent situation in women. And if women are taking oral contraceptives, hormonal supplements, or after postpartum, after you have a baby or something like that, that's a state where the body is healing, and that can cause increased risk of stroke. Next. So race and ethnicity. So it does play a role. Genetics are not the same everywhere. So African Americans have double incidence of stroke compared to Caucasians, and Hispanics as well. And American Indians also have a higher risk for but less than African Americans. The reason for this disparity is the prevalence of high blood pressure, diabetes, and obesity. So risk factors for this health of your blood vessel is high blood pressure, diabetes, smoking, things like that. And genetics plays a role too. So that's why different races, different ethnicities have different risks for stroke. So Caucasian, men and women, they'll have more disease in the neck. And then in our population, or in the Asian population, they will have more disease in the brain. It's just the way the genetics are. It's more prevalent there. But also in the African American community, there's more high blood pressure that's not well controlled, or diabetes that's not well controlled, or obesity that's not well controlled. And those risk factors add up over time. So if I have obesity or diabetes or hypertension untreated for a long period of time, that's a setup for heart attack and a stroke. And we talked about how a stroke is kind of like a brain attack. A heart attack of the brain. Next slide. Genetics plays a big role. Like I said, there's different types of strokes and different types of people. So African Americans, they have an entity called sickle cell, and those sickle cell makes you a very high risk for strokes. In Asian population, they have more strokes because their blood vessels in the brain, the smaller blood vessels, get injured more than the bigger blood vessels. In Caucasian population, the bigger blood vessels are more damaged than the smaller ones in the brain. So, but the ultimate problem is a stroke, no matter what the disease, what artery is the problem. So genetics does play a role. However, it's an uncontrolled risk factor. It's unfortunately we can't modify it. But the things that I want to highlight more is the modifiable risk factors. These are things that we can do. Can I lower my cholesterol? Can I lower my BMI or my weight? Can I work on my high blood pressure? Yes. So these are things that are preventable. These are things that I, as a stroke physician, concentrate on. And number one, I want to bring to your attention is high blood pressure. High blood pressure, if you have high blood pressure, that pressure is being transported by your blood vessels. And that blood vessel, if you give it high blood pressure over time, that blood vessel gets injured over time because it's getting so much pressure that it starts to become more and more stronger, and it gets stronger to counteract that blood pressure, and it gets smaller, 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 until the point where it cannot give you enough oxygen, and that causes a stroke. So high blood pressure damages blood vessels over time. And in my opinion, that's number one culprit. So if you have high blood pressure, please get it treated. Go to your doctor. The goal for high blood pressure to prevent stroke is less than 140 at all times. Now you can have 150 times, but on average, if you take your blood pressure 3 or 4 times a day, on average, you should be less than 140. I know a lot of people don't take their blood pressure, or they don't have a cuff at home. I do tell my patients to have cuffs at home where they can keep their blood pressure logs and talk to their primary care doctors about fixing that. Now you can treat it by lifestyle modification. So if you have, you can have a low sodium diet, or you can treat it by medication. I know a lot of people don't like medications, but unfortunately, I'd rather you not have a stroke than have medications. So medications are good, especially with refractory blood vessels, of high blood pressure. So please take your blood pressure regularly. And if you need to be on a medication, it's not a bad thing. You're actually preventing stroke long term. So that I want to emphasis on high blood pressure. That's number one. That's one of the things that brings my patients or brings people to the hospital. Next slide. Smoking. Smoking is I'm going in order. What harms the most to the blood vessels? So smoking, it promotes inflammation in your blood vessels. It decreases oxygen. It increases the clotting factors in your blood. Increases aging. I'm not saying that you age, but your blood vessels age faster. I would say that over time, all these blood vessels are under stress for high blood pressure, cholesterol. If you add smoking to it, you're actually increasing that blood vessels age much faster than it naturally would. It lowers the good cholesterol and it raises blood pressure. So there's nothing about that is good. So there's no good smoking sequelae overall. So it does promote strokes long term. And not on top of that, it also promotes heart and lung damage. So if you are smoking, please reconsider. Excellent. Diabetes. So diabetes, just your sugar in your blood is very high, and it's uncontrolled. And when sugar in your blood is very high, it actually sticks to the arteries. And when it sticks to the arteries, it actually creates inflammation. It creates high blood pressure. And it not only in the brain, it affects the heart, kidneys, liver, bone, the foot, and then it causes nerve damage as well. So diabetes is something that hurts the entire body because your blood that has a lot of sugars everywhere. So it impairs circulation. And eventually, with diabetes, your risk for stroke goes up, just like smoking. Next slide. Cholesterol. We talk about cholesterol all the time. A lot of people say, hey, we need to go walking. We need to take cholesterol medications. We need to exercise. We exercise because we lower our cholesterol. We improve our blood pressure. So all these things are linked. When you injure your blood vessel or when you have high cholesterol, these cholesterol particles attach to the blood vessel. And you see that artery on the right side with the clumps of cholesterol attached to it? Look at the artery right next to it. That artery next to it that says normal artery, that is fully patent. That tells me that the blood flow to that artery is going to be 100%. However, if you look at the artery on the right side, that artery now it's clumped. Now that artery is now transporting about 50% of blood flow to your brain or your heart. So that's how cholesterol blocks the blood vessels And eventually, if it gets too narrow, then the oxygen cannot get to your heart, to your brain, and ultimately causes strokes and heart attacks. So that is why we like to lower the cholesterol in all our stroke patients, or to prevent. So you've heard of Lipitor, Crestor. Those are the medications that are proven to lower your cholesterol, your bad cholesterol. So it prevents further clotting of these arteries. Next slide. Atrial fibrillation. So atrial fibrillation is a very, very, very high risk for stroke. Now, atrial fibrillation is it happens as if you get a heart attack, or if your heart is under a lot of stress over time. This atrial fibrillation is basically miscommunication between the heart chambers, and it kind of stagnates blood flow in the heart. And as you stagnate blood flow in the heart, it forms little clots, and these clots can go to the brain or any parts of your body. And when these clots go to your brain, they cause strokes, and these are major strokes, and they create a lot of disability in patients. So atrial fibrillation is something that I take very seriously as a stroke doctor. And there are medications that need to be placed, especially if somebody has atrial fibrillation. So warfarin, Pradaxa, Xarelto, and Eliquis. These are 4 medications that prevent that clot to being formed. And if you don't have history of atrial fibrillation, and unfortunately you get a stroke, then I put you on a little monitor for 30 days or 60 days to look for atrial fibrillation so I can treat it. Next slide. So let's say if you have atrial fibrillation, which is abnormal heart rhythm, we look at other factors to treat what's your risk for a stroke. If you have atrial fibrillation and you have any one of these, high blood pressure, congestive heart failure, diabetes, age of 75 and above, previous stroke, a vascular disease, or if you're female, then your risk for stroke is even higher. I don't mean to scare all females here, but unfortunately that's proven that atrial fibrillation in females, you'll have more risk of stroke than in your male counterparts. And so that's why we're very aggressive in treating atrial fibrillation in females and the elderly and anybody who has high blood pressure. Next slide. So carotid disease. So you have 2 arteries that go up to the brain called the carotid arteries. And the picture on the right side, you'll see that where the arrow is and the square, that artery is going up and it gets narrow. That narrowing of the artery, imagine if that's a highway and if you have a bottleneck, that's the cars are not going to go through really fast. So when that occurs, the brain gets drained of blood flow. And when the brain gets drained of blood flow, there's no oxygen to the blood, to the brain, and that causes strokes. And we call that, we may detect that on somebody that came in for something else. Maybe they came in for belly pain, and out of nowhere we found they have a carotid disease. Those are asymptomatic, meaning that hasn't caused any symptoms yet. So we don't like to treat that with stents. We like to treat that with blood pressure medications, blood thinning medications like aspirin and Plavix, because it hasn't caused any damage to the brain. However, if you have symptoms, like if you have a stroke or a mini stroke or a TIA, then we go very aggressive with those blood vessels. Then we can put in stents in that artery, or we can do surgery to open that up. So that is one of the risk factors for stroke as well. Next slide. Risk factors that are modifiable and that contribute, not as much as high blood pressure, not as much as smoking, and not as much as diabetes, are sleep apnea, migraines, replacement hormones, substance abuse, and excessive alcohol. They do cause strokes in the long term. They increase your risk. So, next slide. So physical activity is key. We exercise. If you go out for a walk, if you exercise daily, you're ahead of the game. You're basically, with exercise, you're promoting blood vessel health. Reduces blood pressure. It controls diet and sugar, and reduces obesity. So by indirectly, you're lowering your cholesterol, and it improves your sleep overall. Brain heals with sleep. So you have to get adequate sleep as well. So physical activity is key in preventing stroke. Next slide. Now we're going to go into, medications wise. We looked at what can cause strokes and unhealthy blood vessels, but we also have a degree of medications that we can give to reduce your risk even further. Let's say if somebody has high blood pressure and diabetes, and they say, hey, doc, I want to reduce my risk for stroke even further. So I give them something like aspirin or Plavix or Brilinta. These are blood thinners that, the clump that forms in the arteries, it decreases the amount of those. And these medications help reduce the risk of stroke. Not only stroke, basically stroke is a blood vessel problem. So where are blood vessels? Blood vessels are everywhere. So blood vessels are in the heart too. So that's why your cardiologist will give you aspirin as well. And your neurologist will give you aspirin as well. It does dual roles because your blood vessels are everywhere. And with atrial fibrillation, we talked about, we treat with warfarin, Eliquis, or Altura-Perdaxa. And these are more powerful blood thinners. But if you have, that's only accounted if you have atrial fibrillation. Next slide. So God forbid you have a stroke. Time is very key to coming to the hospital, especially in the first few minutes to hours. It is very key. The minute you stop blood flow to the brain, that's when the damage starts. And we have technology, we have resources to reverse all that. Only if you show up on time. Yeah. So we have a clot buster medication. So if you have a clot that goes to the brain, I can give you a medication that actually dissolves the clot. And it's called TPA or tenecteplase. And those are medications that I can only give up to 4 hours. So if you come after, let's say, after 4 hours, I cannot give you that medication. Okay, it's not safe beyond 4 hours. It can cause bleeding after that. Now, there are also, let's say if that I give you that medication and it doesn't help, then we can actually go in and take that clot out. So we go through the arteries of the hand or the leg, and we go all the way up to the brain, and we take these specialized stent appearing web-shaped devices, and we clamp that clot and we take it out of your body and restore blood flow. Now that's time limited as well. That we can do up to 24 hours. However, having said that, your brain starts damaging at second number 1. So if you can't come in 6 hours later and not have, brain damage, you have to come in right away. So we did that twice last night in our hospital. 2 people came in with clots in the brain. We took them out, and we're just waking them up slowly, seeing if we were able to, salvage some part of the brain. Next slide. So treatment of hemorrhage. So hemorrhage we talked about was a blood vessel that pops in the brain, and that could cause multiple different types of problems. It's either in the brain or outside the brain or between the scalp and the brain. And the treatment for that is either lowering the blood pressure, because the blood pressure is the one that caused the hemorrhage to begin with. Because if I provide a lot of pressure, just like a balloon, right? Your arteries can flop up like a balloon. if you keep giving pressure to a balloon, it'll eventually pop. So what we do is we lower blood pressure. And then unfortunately, there's no medication for a hemorrhage. We have to do surgery. So we open the scalp and we take the blood clot out. Next slide. So in conclusion, stroke is very serious and it can occur at any age. I've taken patients that have had strokes in their 20s and in their 90s. It increases as you age, the risk of stroke, especially if you have diabetes, high cholesterol, lack of exercise, or you smoke. So those are the risk factors that you want to reduce. You don't want to give, if you're smoking, give up smoking or reduce smoking. High blood pressure. If your blood pressure is constantly high, unfortunately, you're going to have trouble with heart disease and brain disease in the future. And high cholesterol. Cholesterol medications lower your cholesterol. That does help considerably. So, and things like obesity, physical inactivity, and poor diet contribute. So those are things that are modifiable. And what I want you to take from this lecture is that these things will keep you out of the hospital. If you control your blood pressure, smoking, high blood and diabetes, and activity. These are things that, you don't want to see people like me in the hospital. I mean, I'd love to see you out in the mall or something, but not in the hospital. These are things that you need to work on if you have them. Next slide. So prevention starts with you and your doctor. Use a little more capital because actually you have to have the emphasis and the notion to actually go and do something about it. So your doctor can help identify these things. So you don't know your cholesterol is high, but your doctor will send a test to see. Or you may know, and then you may check where you are when you started medication. And then if your blood pressure is super high, your doctor will put you on a medication to prevent or get it down. There's this misconception that medication is bad for us. Yes, I would like my parents and myself to be off medications for sure. However, the alternative is a stroke. So I'd rather have my parents on a medication every day than have them have a high risk of stroke. So medications aren't always bad. Please don't think like that. And basically look at the blood vessel of your brain. So if you've had a small stroke or you had a TIA or a minor stroke, your doctor can order studies, ultrasounds to look at your blood vessel health. So what I want you to take here is that we can control your risk for stroke. And it all starts with you and looking at blood pressure, diabetes, and your doctor. Next slide. These are basically, this is a thing that we give out to our patients in the community. These are things to eliminate your stroke risk: lose weight, drink less alcohol, stop smoking, consume less sodium, or don't drink alcohol at all, eat healthy, and exercise. Those are things to eliminate your lifestyle risk. And then medication-wise, high blood pressure will give you high blood pressure medication. Cholesterol, we can give you cholesterol medications. With atrial fibrillation, which is abnormal heart rhythm, we can give you medications to prevent any clots. Diabetes, you can work on cholesterol, your diabetes with diet, or there's medication associated with it. So let's say, for example, you have diabetes and you don't want to take insulin. However, let's say if your diabetes is not controlled, there's no harm in taking insulin. This is something just naturally that your body is no longer making. So please don't think medications as bad. These will actually keep you out of the hospital long term. Next slide. So be fast is something that I teach a lot of in the community. So it's an acronym to help you identify stroke symptoms. B stands for balance. So if you lose your balance, think of a stroke. Eyes blurred or vision loss, that's the E. F is for facial droop. The most common thing that people notice is the facial droop. So one side of the face is droopy. Arm weakness. So both arms up, one goes down, or you can't lift the arm up. One-sided, that's a stroke until proven otherwise. Speech difficulty, if I can't understand or if I can't get my words out, that's a sign of a stroke. And we put that time in there because time is key to get that stroke taken care of. You must present to the hospital within an acceptable time window, and so we can reverse the effects of stroke. Next slide. Now this is the interesting facts on stroke data. This is data from the CDC. It looks at the concentration of strokes in the United States. You can tell there's a disparity in the right eastern side of the United States, and those, those mid U.S. states, those maybe they have lack of resources, maybe they have higher population of African Americans, who take less care of themselves. So those, it's very heavy, the stroke symptoms in the mid to eastern area. In California, it's a mix. In Kern County, you'll have a little bit more. In Orange County, a lot of people take care of themselves overall, so we have less prevalence of stroke overall compared to the rest of California. Next slide. And I want to open this up for questions for anybody that has any questions regarding stroke.
There is a question in the chat. Somebody asked, wait, there's a few actually. Sleep apnea. If someone is using CPAP machine, does this help reduce the risk of stroke?
Absolutely. So let me give you the scenario where somebody's snoring and somebody has lack of oxygen at night. So if you have lack of oxygen at night, your heart has to work harder to pump that same amount of oxygen to your body. So your heart over time develops problems over time, and that over time will cause heart attacks and strokes. So it's less than high blood pressure, however, it's still real. So if you put a CPAP on and you have a open passageway through the entire night and you have adequate oxygenation, you're reducing your risk of heart attack and stroke. But you must use it religiously and every night.
Thank you for sharing, doctor. And then somebody wanted me to reshare the BFAST slide, so I'm going to put that up on the screen. If you want to take a picture, you guys are welcome to do that. And if anyone has other questions, please go ahead and share away. You can unmute yourselves and ask.
So you guys are experts in stroke?
Yes. No, go ahead and unmute yourselves and ask away.
It's scary.
It is.
The reason why I make it is that these are things that are very controllable. So if you take care of your body and your cholesterol and your high blood pressure, it'll keep you out of the hospital.
Does it have any special diet for this purpose?
So the heart diet or low sodium diet or more greens, that's universal. That's universal because overall health of your body is promoted. And when you're overall promoted health, then basically you're also promoting stroke health as well.
Could it be a hereditary also?
Yes. So hereditary, like if your grandfather or your dad had early stroke, then the risk of stroke is higher. Just like heart disease, if your dad or your mom had a stroke or heart attack earlier, then it can run in the families to have early strokes and early heart attacks. Yes.
How can we find out hospitals in our area that are good for strokes, or they have the staffing and the equipment and the knowledge?
That's a pretty good question. So Joint Commission This is a accrediting body that gives authorizations for stroke care and also creates standards for hospitals. It's called the Joint Commission. The Joint Commission comes to our hospital every 2 years to make sure that all our equipment, all our physicians, all our nursing staff are well educated in stroke and our equipment up to date, and we're doing beyond, if not standard of care. So this list of what we call comprehensive stroke centers are listed in Joint Commission website. And I can tell you there's only 3 in Orange County. That's St. Jude's,
Right.
UCI, and Mission Hospital.
St. Jude's.
You see,
How
You
about
see-
Riverside County?
That's I don't know about Riverside County.
You don't know that.
Okay.
what about Kaiser? Does Kaiser have this?
Kaiser has capability to treating stroke, but they're not comprehensive stroke centers. They will be able to provide good care for stroke. However, sometimes they have to transfer to us or other hospitals.
Thank you.
Excuse me, in the Orange County, you said St. Jude's and UCI. What was the third one?
Mission Hospital
Mission Hospital. Where is that?
in Mission Viejo.
Oh, okay, Mission Hospital. Okay.
You will meet Dr. Rahim there.
Where in Mission Viejo?
Yes, I work
Mission.
at Mission Viejo. I'm the director.
All right, we can then suggest to take us there to Dr. Rahim.
Wow.
Tell them to take you to the closest stroke center.
Yes.
Yeah,
It also has
What's the value of taking your blood pressure daily? Because my doctor, they put me in a study and gave me this gadget, and by the way, I've not been following. And after this presentation, I will follow their instructions. But why is that suggested?
So if you don't know what your blood pressure trends are, then I recommend taking your blood pressure
For
at least,
trends. Okay.
3 times a day. So what
Okay.
that tells me is that you don't have to do it for a long period of time. What that tells me is that if you take your blood pressure in the morning, what is your blood pressure in the morning? Then you take it at noon or lunchtime. What is your blood pressure at noon? And then what is it at night? So that tells me 3 different points in your day where morning could be okay, your lunchtime may be high, and then your evening time may be okay. So that tells me that you need a little bit more medication during lunchtime. So that's how it helps taking your medications long term. Now, when you create a pattern where then you can take it once a day, where we're making sure that that it's been constant for a while. But I instruct my patients, especially after a stroke or after, take it 3 times a day, write it down so you can tell to your doctor that, hey, in the morning my blood pressure was high, but in the evening my blood pressure is low. So that tells the doctor, hey, start your medication overnight or in the morning that covers in the morning only. So you don't have to be overtreated.
Does it matter if it's before lunch or after lunch?
It doesn't matter. Actually.
Okay.
if you
I
are
can give you a
taking,
hypothetical. If you give me 4 points of after lunch or before dinner, that's even more information. So that's even better. But I don't want to get you, exhausted of taking medications all day or blood pressure all day.
if you are taking blood pressure medicine, you still check your blood pressure 3
Yes.
times.
Yes. Because you never know. Your blood pressure may be high at 4 o'clock, and it's normal when you take it.
I've seen some apps lately that for taking the blood pressure. What do you think of those?
I think that's fine. It'll create a log for you. And if you have a log that takes your blood pressure or an app that takes your blood pressure, that's perfectly fine. You have multiple areas of data that can treat at that point.
Does Apple Watch do that too?
Apple Watch does not do blood pressure
It does something though.
it does atrial fibrillation. It does
Oh, okay.
oxygenation.
Uh-huh.
Do you have to take your blood pressure regularly for a couple of days to exactly know your blood pressure is high and then start on medication?
Yes.
Okay. Roughly how many days?
Usually about 2-3 days.
2
you'll
to 3.
know.
Oh,
Yeah.
thank you.
Because one day you may be, maybe more stressed or your blood pressure is high, and the next day may be low. So
Right.
overall, you may not need a blood pressure medication. It's just that, once in a while your blood pressure is high.
Correct. Thank you.
It's not, exact science that everybody's gonna be different, and your management overall on average has to be okay.
Correct.
Is there any symptom that you know that you are having you have a high blood pressure, you have a headache or something
Yes, you have
like that?
headache, you have dizziness, that type of thing. Yes.
All right. There is somebody with
Right.
iPhone. You have a question, you can unmute yourself. Let me try to do that for you. If not, you can always type down your question in the chat box. Dr. Rahim, my question is, post-COVID, or, COVID is not completely gone, have you seen a rise in strokes?
I did see a rise in strokes during COVID in the young population.
Oh,
Because when they get COVID, what COVID does is, and a lot of other viruses do this also. Your body goes into inflammation, or this inflammation mode. When the body goes in inflammation mode, your blood clotting gets a little bit more ramped up. And when your blood clotting goes ramped up, then you can form little clots that can cause strokes. So I did see more incidents of strokes in the younger population after COVID, sorry.
But the COVID is still around.
The COVID's still around, but I don't see as much stroke anymore. Now what's COVID, the leftover COVID is not as harmful as the initial COVID.
Yeah, as severe.
Yes. So that's why we don't see severe symptoms anymore.
All right, iPhone, whoever you are, please speak up. We can hear you.
Yeah. Okay.
This is
this
Gani.
is all-
Can I talk now, Gani Bhai Sheikh?
1 second, Uncle. We are going to listen to another question
okay.
first, and then it'll be your turn. Thank you for your patience. Go ahead.
Okay, thank you, Zainab. I just have a quick question. Although I was listening, but maybe I missed out the part where he was talking about afibrillation. My niece and nephews, they all have a problem of heart racing, the so-called heart racing. Is it the same as what you call the fibrillation condition? Is it the same thing?
So heart racing, AFib can be a part of that. However, heart racing can be multiple things. It can be just, your heart just beating faster, but it's regular, meaning that it goes in a pattern. This, and this. So your heart goes this first, this. So it's a pattern. It goes.
Okay.
So that if you do it 150 times or 140 times a minute, you can feel your heart racing, but that's absolutely normal. There's nothing wrong with that. It's just that your heart's racing a little bit. It'll tire out. However, with AFib, your heart's racing, but then there's no pattern. It's not like it's not like that. It's that's AFib.
Yeah, the rhythm is not normal. That's what
rhythm
you're
is
saying.
not normal.
Oh,
And
okay.
that rhythm not normal, that's AFib. So heart beating fast, there's two different types: rhythm normal, rhythm not normal. And not normal is AFib. But if they're fairly young, they probably have a
They
normal
are.
rhythm.
Hello, sorry.
All right.
Yeah, they are young, and that's why I was wondering, why it's happening and what could be done with that.
So what they would see a cardiologist, and the cardiologist will put a little sticker here on their chest, and basically that sticker will be there for 14 days. It'll monitor their heartbeat for the 14 days. And that 14 days will look, is it normal rhythm or abnormal rhythm? And see that, do they have any AFib in that 14 days?
So if the rhythm is normal, so it's not dangerous, it's okay?
It's not dangerous. No.
Oh, okay. All right. I got it. Okay. Thank you so much.
You're welcome.
All right, Uncle, go ahead, ask your question.
Two questions. I'm told that atenolol, which is a heart medicine, everybody should take it nighttime. It doesn't hurt. It's a pretty good preventive medicine for the blood pressure. Is that true?
The general consensus that if anybody can take it, I don't know who told you that, but if you don't need atenolol, you don't need atenolol. You need it for blood pressure and you need it for heart rate. Now, I wouldn't recommend just taking atenolol to general public without the indication of taking atenolol.
Because that was I was told by some other doctor that at least a minimum 25 milligram doesn't hurt you. You should take it regularly because that really slow downs the heart the nighttime, and it does help.
It does slow down the heart, but the thing is, let's say if your normal rhythm is in the 60s, a lot of patients, their rhythm may be in 60s or 50s. And if you take atenolol and your heart rate goes down to the 30s overnight, then that's counterproductive.
It is, yeah.
I maybe the doctor was trying to say something else, but I wouldn't recommend that as at least a stroke doctor.
The second question, doctor.
Sorry, go ahead.
Do you take the HMO, the scan HMO?
Do I take HMO as insurance?
Right.
So I'm an emergency doctor, not emergency. Like I'm in a hospital doctor. I don't have a clinic.
We don't have.
We take care of patients that come in as a stroke or ICU in an emergency.
Yeah.
But yes, we do. But the thing is that if a stroke is happening, somebody, I don't look at their insurance and treat them. We treat them, but we do take HMO. Yes.
Okay, but you are in emergency doctor, so you don't have a regular clinic. I mean, that's all right.
I don't have a clinic. I am only an ICU doctor. Yes.
Thank you. That's good. That's all I had.
What's the current thinking on aspirin, daily 81 milligram baby aspirin?
So in my opinion, if you don't have any risk of bleeding, then aspirin is good. So if you have diabetes, if you have high blood pressure, if you have any one of these symptoms that we talked about, obstructive sleep apnea, diabetes, or you have high blood pressure, then aspirin is very good for you. But if you just take aspirin with no risk factors, then you're just increasing your risk for bleeding.
That's why dentists always ask you, don't take aspirin before you come to me. Right.
Your dentist?
I mean, most of the time, dentists will tell you, don't take the aspirin for one day before you come to me.
Exactly, yes. Right. Yeah, they don't want you to bleed, yeah.
All right, wonderful, Olivers. We have time for one more question. If not, we will let Dr. Rahim end here.
Thank
any
you
last
very
question?
much.
Thank you so much. It was such a pleasure to have you on Olive Online. I hope you enjoyed meeting our Olivers.
I had a pleasure. Thank you so much for inviting me.
Very good presentation.
Of course.
Olive Community Services is a 501c3 nonprofit organization based in Southern California that provides culturally appropriate services to seniors, their family, and the community. Through its physical and virtual interactive programs, Olive engages participants in a variety of ways that promotes health and well-being. To learn more about Olive Community Services, to get involved, or to make a donation, please visit www.olivecs.org or email info@olivecs.org. Be a change maker, and together, let's live, learn, and thrive.